Good afternoon, everyone, and welcome to our Protect Our Province COVID-19 briefing for Alberta on Monday, September 13th, 2021. We are live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is being shared in ASL. To ensure access to completely accurate information, closed captioning will be uploaded after the live stream is complete. This conversation for the public is being shared live on YouTube, Twitter, and Facebook. We are hopeful this will increase the accessibility of our briefings for all Albertans. The Protect Our Province COVID-19 briefing is a regular panel of doctors and experts. We will endeavour to bring timely, accurate updates on the COVID-19 crisis in Alberta and take questions from the media. The views of our panelists are their own and do not represent any institutions they may be affiliated with. We have collectively gathered here as concerned Albertans attempting to ensure that everyone in the province has access to as much information concerning COVID-19 in Alberta as possible. In addition to our regular COVID-19 analysis for Alberta, we will focus today's briefing on ICUs in our province. Welcome back, everyone. I would like to begin by correcting my introduction to today's briefing. ASL will be added into the video after the live stream airs. This inequitable access is a concern for us, and we will continue to improve our process to prevent this from happening in the future. To begin with, I would like to welcome Dr. Vipond to provide an update on COVID-19 numbers in Alberta. Dr. Vipond.
Welcome, Alberta. Sorry to have to rain on everybody's parade today. The numbers are out, and I don't think to anybody's surprise, they are atrocious. And I think it's really important to understand how predictable this is. Done some interviews today and just thought about some of the ways the numbers have rolled out, and really we've had exponential growth for months now. Arguably first noted an uptick in mid-July, and this is the end result. I mean, this was entirely preventable, entirely predictable. In some ways, it's pretty obvious this was intentional to happen in the way that the policies have rolled out, because we've known exactly what to do throughout. So here's your numbers. We're doing 3 days today, Friday, Saturday, and Sunday. So the numbers for each day, 1667. That's a 27% increase over last Friday's 1312. Saturday, 1503, a 4% increase over 1447 the previous week. And a really surprising number for Sunday. Sundays usually our quietest day. People don't tend to go in and get tested on Sundays. But yesterday we had an astounding 1598, which is almost double, 96% increase over the previous week's 813. Overall, our 7-day average is, next slide, please, is 1468 per day, which is just a slight uptick from the week previous at 1268. Looks pretty steep on the curve, though, and you can see that their curve has re-steepened, mostly thanks to that one set of numbers on Sunday, completely overlapsing the week before. One of the things, I'll get to that at the end. I'll go to the next slide, please. Percent positivity. Very flat at around 11 to 12% and very similar to the week previous. Next slide, please. This is the Delta curve, and we've been told by Alberta Health Services Precision Laboratories that they're no longer going to be testing for variants of concern. So this will probably be the last time I present this. I just want to point out that our average percent cases per day has been very stable. From the 2nd to the 6th, we've been anywhere from 88% to 91%. I'm not so sad about losing this data. I think it's pretty obvious that Delta is overwhelmed everything. We're not sure what that other 9% is. It doesn't seem to be backfilled by the other variants. But as long as that number doesn't start to drop surprisingly, then we can be pretty confident that Delta is really the only thing out there. If you have COVID and you're pretty sure you have Delta, and I don't think that this reporting is going to change that. Next slide, please. So this is the worst slide. This is where things are really getting out of hand, both our hospitalizations and our ICUs. The first thing I want to point out is that the data for inpatients is notoriously unreliable. It changes abruptly over time. So the data that I'm going to tell you today is likely not accurate for inpatients on the ground. It's pretty much 100% on for ICU, but the inpatient numbers get revised day after day. And if you want to look at the exact changes, you can look at my Twitter feed, because I'm documenting that, because I'm really concerned about the fact that when Alberta Health Services releases the numbers, it looks less bad than it really is. So just going over the last 3 days, Friday up 29 to 578 for inpatients, Saturday plus 10 to 588, and Sunday plus 17 to 605. And the ICU, I think, is where, again, the numbers are more accurate and at the same time more concerning. Friday up 12 to 181, Saturday up 4 to 185, and Sunday up 13 to 198. And I'll just mention that there's been a news story today out from CBC that said that AHS was releasing the numbers for today at 202. So I'm not sure if that's just more up-to-date information than the 198 that's being presented, or more accurate. So 198 last week was 137. So in a 7-day period, we've had a 45% rise, which means that the ICU doubling time is 14 days. And it's been 14 days for quite a while. So 2-week doubling time. And that just means that we're in big trouble. There's no sign that this is flagging. If anything, my concern is that as schools are now reopened, that we'll have higher numbers going through to the general community. There's a bit of a balancing act, because we know that we're going to have higher numbers of younger people impacted who tend to have lower severe outcomes like ICU. But as they spread it into the community, I'm worried that ICU number, there's nothing to stop it. It's just going to keep going. So when you see us healthcare workers panicking over 198, just imagine in 2 weeks when it's about 400. We are in big trouble. Next slide, please. 17 deaths today. Oh, sorry, reported today, and that's for the entire weekend. Next slide, please. This is the demographics. This is the age demographics, looking at the various curves. I just want to really point out that for the majority of this Delta wave, this intentionally cruel wave, it's been the 20 to 29s that have been leading the pack. But those next two numbers right underneath that are the 12 to 19 and the 5 to 11, racing neck and neck upwards. And I don't think that's a surprise to anybody. What happened on the 1st of September, schools opened, and I fully expect those two age demographics to be leading the Delta wave by the end of the week. So keep an eye out for that. Everybody loves a prediction, right? This is the worst kind of prediction. You can take off the slides. I just want to present one more set of numbers, and this is something that I started to do over the weekend. And I did this back in November, December. We have really good statistics on COVID. Delta's a bit of a different beast. Yeah, I think we can count on the case hospitalization rate and the case ICU rate as being quite accurate throughout this wave. And I say that because the average of both of those have ticked up from the third wave. So I think in the third wave, if my memory serves me correct, it was 4% hospitalization case rate and 0.7% ICU case rate. And now at this point in the intentional cruel wave, we have the hospitalization rate as being 4.2, so actually up from the third wave, and the ICU now at 0.8. So what I've been doing is I've taken the daily numbers and I'm adding them together. So I'm using those case rates to try and figure out what today's cases mean for future hospitalizations in ICU. So I did that for Tuesday, Wednesday, Thursday of last week. And those 3 days alone equaled 178 hospitalizations and 34 ICU cases on top of what we've already seen just from 3 days of cases. So over the weekend, Friday's numbers represent 70 hospitalizations, 13 ICUs. Saturdays will represent 60 hospitalizations and 12 ICUs. And Sunday will represent 67 cases and 13 ICU cases. And providing that these, rates remain constant. So if we add those to last week's numbers, just from 6 days, so less than a week, we'll have 375 hospitalizations and 72 ICU cases. And so that's why we're in trouble, everybody. I don't know what to say. I feel so helpless and so guilty that we haven't been able to do more. I know it's not our responsibility. We're not policymakers. But it feels that collectively as a province and as an individual, we haven't done enough. And I'm so sorry. Back to you, Michelle.
Thank you very much, Dr. Vipon, for your ongoing transparency and care for Albertans and wanting to give us the information that we need so that we can do the best that we can for our families and those around us. I would now like to bring Dr. Schwartz into the conversation to add any additional thoughts that he may have on the COVID-19 situation in Alberta and give us an update on a letter today released by 67 infectious disease specialists in Alberta, or maybe up to 69. Dr. Schwartz?
Thank you, Michelle. Yeah, so I echo what Dr. Vipon said just about the increase in cases. It's all been very predictable, and it's hard to feel anything but despondency right now, and profound disappointment that we're in this situation. And then making matters worse is the fact that outside of our hospitals, we have people who are jeering us and obstructing access for our patients, and it's a bit of insult to injury. So nonetheless, we're going to continue doing what we can to care for Albertans. As infectious disease physicians, we are also privileged with the vantage point of understanding how infections spread, and so the public health ramifications of certain actions. And so we have been disappointed to not have a more engaged role in advising this government, but nonetheless, we've taken the extraordinary measure of writing an open letter to Premier Jason Kenney today. So this was a letter that was signed by 68 infectious disease physicians from across the province, which it is quite remarkable in and of itself, because if you've ever met an infectious disease doctor, you know that we all have different opinions. Famously, we say that there's among 10 ID doctors, you could get 11 different opinions. And so in this case, there's not much room for disagreement. Everybody agrees that, we're in the midst of a disaster and things are only going to get worse before they get better. And it really is absolutely critical that the government take strong and decisive action with the utmost urgency if we are to avoid absolute devastation to our healthcare system, to society in general, and resulting predictably in preventable lives lost. So we really are in a lot of trouble, as is clear from the ICU numbers. The consensus among the 68 infectious disease doctors is that we need a urgent intervention. Specifically, we need certificates of immunity. We need people to be able to prove their vaccination status, and this must be mandated in order to access public spaces with the purpose of accessing non-essential services. So such access to indoor buildings needs to be limited only to those who could prove their vaccination. This is done for a couple reasons. One thing is it is to keep Albertans safe. It is to keep unvaccinated people safe. It's to keep them out of the settings that are at the highest risk for them to become infected themselves and for them to infect other people. And it is to allow for those who are vaccinated to continue to contribute to the economy. Ultimately, this is good for the province. And then thirdly, it is to incentivize vaccination uptake. And so we don't continue to go through these cycles. This is what is going to prevent further waves and further broader lockdowns. There was clear consensus that is absolutely required. The next question is, well, what if the government doesn't introduce these measures? They have expressed a lot of reluctancy to embrace vaccine passports, and in fact, they just sent out a fundraising campaign on the predicated on the opposition to such documents. And so we have called for, as an alternative, wide-ranging restrictions that essentially act as a firebreaker to basically shut down non-essential businesses, to limit gatherings to 10 or fewer individuals, and a work from home order. So in order to avoid these types of widespread lockdowns that we saw in earlier waves, we really do need to have a way to very urgently decrease new cases. I've been asked, do I think that it is likely that the government will go for a lockdown if they don't go for vaccine passports? And my answer to that is, whether they go for it or not, a lockdown is happening. And so, in medicine, we have quite a macabre statement that is really a truism, that is, all bleeding stops. So if a patient is bleeding, you either stop the bleeding through an external intervention, or the bleeding will continue, the patient will bleed out and die, and then the bleeding stops. It's obviously very dark, a dark concept. We're in the same situation. If vaccine passports are not implemented, there will be a lockdown. That lockdown is either a intentional one by Jason Kenney, or it's going to be one because our hospital system collapses and our society is going to collapse as a result. So this is really absolutely essential that the Premier take decisive and firm action in order to prevent such a terrible fate. So without further ado, I'll give it back to Michelle, and so we can hear from our panelists today.
Thank you very much, Dr. Schwartz. I would love to invite our panelists to join us. With us today, we have an ICU nurse to provide some insight into what is currently unfolding on the ICU floors in Alberta. Ellie O'Graysick is a nurse educator from MacEwan University with clinical practices in intensive care and labor and delivery. Welcome, Ellie. Also with us, we are joined by Dr. Buchanan. Dr. Brian Buchanan completed his training in internal medicine, critical care medicine, and critical care ultrasound. He practices as a general system intensivist at the University of Alberta in Edmonton and is a flight physician with Shock Trauma Air Rescue Society, aka STARS. Thank you so very much to both of you and Dr. Schwartz for joining us today. I think I would like to start out this conversation with asking both of you, what is different in the ICU today than it was 2 years ago? As an Albertan, I've heard for a long time about how precarious our ICU situation can be in a regular year. And so I know for a lot of our followers, when we talk about things like the system collapsing or the dire urgency of making some real changes, it can be hard to visualize what exactly you guys are facing day to day. So yes, I think that would be where I would like to start. Either of you willing to give us a day in the life comparison of then versus now?
Dr. Buchanan, you go ahead. Okay, sure. So, you know, in the ICU, we tend to run pretty slim margins. You know, intensive care beds are fairly expensive. They're fairly resource demanding in terms of the requirements for physicians, nurses, respiratory therapists, occupational therapists, and on the list goes. And further, running machines. So it is a very expensive endeavor, and so we generally run with pretty slim margins, and we really do make it work. You know, we have basically a mishmash of different kinds of people that will come through our door, whether it's those with you know, with pneumonia, for example, or those who have burn injuries, or those that have severe respiratory failure, or you know, bad infections, for example. So you know, we see a number of different problems, and we tend to balance that kind of on a razor's edge. You know, we work intensively, we work as a team. That's the only way to manage it when we are just trying to juggle a lot of priorities. And you know, I think that going through these waves repeatedly, our team has been very cohesive. Like the nurses have done an outstanding job, along with their respiratory therapists and physicians, at coming together and making sure that we can flex upwards and accommodate any changes in ebbs and flows of patient volumes and patient acuities. Of course, you know, you could say that it's busy with 10 people that come in overnight, but the truth is that it could take one person that could consume a lot of resources in the course of 8 hours, that can demand a lot of bandwidth of physicians and nurses. And so we have kind of flexed upwards and downwards as the waves have come, and we've kind of moved locations, and we've tried to accommodate the increases in volume. And I think that's taken a toll on practitioners, and that includes physicians and nurses, and as a list I mentioned before. And because it has been fairly exhausting, it's been tiring to care for patients who are severely ill at high volumes, but also it's hard to care for people that, frankly, that may get better at first on a ventilator, but then may die shortly after. So it has been challenging to care for patients that have been severely ill with COVID, because it's a devastating disease for those patients that are potentially put on life support. And you know, as we've seen over the course of these recurrent waves, you know, the ability to care for those patients has become somewhat impaired, because it's been exhausting. And as this fourth wave has come, we've seen a fairly dramatic rise in a very short time. And I think a lot of people are just frankly exhausted. It's been very tiring, and it's also very hard to be there for someone who's dying and knowing that you just wish you could have prevented it. It's just a really hard place to be, because you know, especially for you know, our nurses who are there at the bedside helping care for these patients, and having people die that, you know, like really no matter what you can do, some patients will still just die, and that feeling is horrendous. And so I think, you know, there's a lot of information packed in what I've just described, but I think, you know, we are always there to adjust up and down. We will always be able to accommodate the increase in volume to a certain extent, but you know, but things have changed over time, because people are now exhausted and tired, and they're also somewhat demoralized by the inability to care for patients, because they're just so ill. So I guess that's from my standpoint. But Ellie, why don't you give your standpoint?
Yeah, so I mean, sorry, very much of what Dr. Buchanan had talked about. There's a few different things for nursing where, you know, our unit that we work on, we aren't always funded to the full capacity of our unit. So perhaps we're funded to 28 patients. We have extra patients come in. We do have capacity within that unit to expand to those beds for a short period of time if we need to. Unfortunately, at this time, our unit is completely full. We've actually expanded into other units within the hospital. So in regards to the bed crunch, we're simply way outside of our boundaries of what we usually would have access to. And unfortunately, that's a big toll on a lot of people. You know, it's on the other units that we've had to displace out of their home space, and also other nurses that we've had to pull in from other areas to help try and maintain the capacity of nurses that we need on the unit. You know, one of the biggest challenges right now, as Dr. Buchanan had mentioned, is the desperation for staffs. So we have a text messaging service that sends out requests for staff. And every single day there is desperation in those text messages saying we're critically short, every single day. And that's been happening for quite some time. You know, the nurses have had to, you know, and I'll speak on nurses, the nurses' role. I can't speak on everybody else's, but, you know, whenever we're in the patients that we're caring for right now with the COVID patients, A lot of them we found out early on that one of the best ways to help increase their chance at surviving was to be able to prone them, so put them on their tummy instead of their back, to be able to have greater lung capacity. But what comes along with that is you need to have a minimum of 5 people to be able to do that, and it's not just 5 people off the street. Of course, it's 5 critically skilled people that are able to do that. We have a respiratory therapist at the head of the patient, and then 4 nurses, perhaps an RT, depending on who's around to be able to help. Physicians also come in and help. Nursing attendants come in to help, and it's very heavy to care for these patients. But what's also happened in that is that several people have hurt themselves and end up off work in that because of the injuries that they've sustained due to having to prone people. A lot of these people are quite obese, and so it's quite physically heavy to be able to take care of these patients as well. Another thing is, outside of the physical space and the demand on nursing, these people are all isolated. So, you're having to gown up. So regular in the hospital right now, you're wearing a mask and eyewear at minimum. When you're going into the COVID rooms, you're putting on N95s, hair covering, shield, gown, gloves. It's quite labor intensive to even get in and out of the rooms to don and doff your gear. So that in itself is quite exhausting. Not to mention, it's if a patient is crumping in a room, you feel this sense of urgency to get into that room to be able to help that person, but you know that you have to do it safely so that you're not hurting yourself as well. The nurses having to spend increased amount of time at the bedside to try and relay information to families that aren't able to come in because themselves are affected. We usually don't have to, we're always a relayer of information. We're always the people that are, along with the physicians, but we're often at the bedside when the family members come in to relay information. But when those family members aren't able to come in, then we really have to be the eyes on the patients. We're doing FaceTimes with an iPad with families, and that is also labor intensive. With this wave, the ICUs really become a family affair. We've noticed that we've had quite a few more families in this 4th wave than we've had previously. So you'll have brothers in the ICU, or you'll have, other extended family members in the ICU where they've attended an event together because there haven't been restrictions. So, they're doing the right thing, but so they'll attend events together and they'll end up becoming exposed and then ending up in ICU. So you've got, several family members coming into ICUs as well. It's very different than what it usually is.
Dr. Buchanan, you are currently muted in order to prevent feedback. Unmute yourself and then please resume those thoughts because I would like to hear them.
Sure. Yeah. Yeah. I mean, I agree with Ellie. I've seen multiple patients where like their family's already been into a ward or to the ICU, or in some cases it has already died. And I think that's the dramatic shift, as Ellie's pointed out. Like, we're seeing whole families. And, I remember in the first wave, the first couple waves, I remember just seeing countless nurses at the bedside with iPads, like just for patients and families on there crying, all grouped together. And I just thought to myself, like, this is devastating. Like, this is the worst. Thankfully we have iPads, but I can't think of a more tragic use of that technology. And I thought, I hope we can avoid this in the future, right? But yet we're right back here. And I think that has been really hard on people because we want families to be there for patients. Like, we really do. It makes it really hard on people, on patients, on their loved ones when they can't come in and see. And this has been just another wave of devastation. And I think, as I've kind of said before, and as Ellie kind of highlighted, every time we have a wave, we have a stress test. And that stress test, like in the last few waves, like I think we've done fairly well with what we have. But every time we get a stress test, there's a little crack here and there, and there's more cracks. And those cracks have built continuously. And that's been happening all across Canada, frankly. And every time it's a little bit worse, there's a little bit more stress. And I think now we're at the point where, I worry that we are past the point of no return. That's my genuine concern.
So can I just interject for a second? So first of all, thank you both for those really insightful comments. Ellie, you were talking a little bit about kind of some of the consequences of spilling over from the ICU into other wards, and so we're seeing that everywhere. So for some people might have the idea that, you know, well, what's the big deal? The bed's the same, you know, the outlet in the wall is the same, you know, the nurse is the same, the doctor's the same. So what are some of the challenges that you can foresee or that you encounter when providing critical care outside of an ICU?
You know, the tough part with critical care is that you have a baseline equipment that you're required to have. So in a hospital like ours, you know, we do have several ICUs, but we are at the point of breaking right now. So whenever you take care of a critical care patient, these people are monitored continually. So we need monitors at those bedsides. We need functioning oxygen, suction. This is very much a respiratory issue. So lots of suctioning. We need ventilators. So there is, you know, there's always concern with ventilators. Are we going to have enough of them? Not only just the ventilators, the respiratory therapists that are associated with those ventilators. So, you know, if you think of our population of healthcare professionals, I absolutely worry about how many nurses we have on a unit. But what's also very concerning, because it is a smaller pool of people, is that how do we have enough respiratory therapists to you know, to kind of get us through this next wave. I was making a joke last weekend when I was at work, because one of the respiratory therapists, I was in a room and he had me change the ventilator settings. And usually that's a no-no. You don't touch the ventilator settings. And I said, realistically, they're going to be having to give us some very quick lessons on how to operate these ventilators if we're going to be able to go into this next wave and be able to pull people through. So you know, not to mention, you know, whenever people are in ICU, they're on all kinds of medication. They're usually sedated, comatose, because we're, you know, they're just not able to breathe. So we have to completely drive out their inert drive to breathe, and maintain them with this, of course, you know, consequences to that. We knock out their blood pressure. So then we have to give them medications to maintain their blood pressure. So we need medications. We need IV pumps to be able to do this. We need people that are able to safely and be trained to be able to do these things. So a lot of floor nurses, they would not normally be functioning or running these kind of medication drips on their patients. So if they aren't familiar with running these kind of, you know, infusions and also giving medications, we also paralyze people. That not only ICU nurses that are trained to do that are able to do that safely. So if we have nurses coming from the ward that just give a medication called rocuronium and knock out the patient's ability to breathe at all, without the support to keep them alive, we're going to run into a huge issue.
You just spoke a lot about the human resources capacity of moving patients beyond the ICU and how that is happening, how different areas of the hospital are needing to be utilized to create what we've been referring to as that surge capacity. What happens when we are out of the surge capacity? A lot of folks have been asking today in the YouTube thread and in the Twitterverse around where will you guys put people next?
I don't know.
Dr. Buchanan, you're muted again.
I'm the worst at this. I think the answer is that you put them wherever you can, like wherever we can have spaces. So we, you know, back, I remember when I was in Ontario, we you know, like a couple of rough nights consecutively with lots of admissions, we started to spill over to the, you know, to the recovery room, for example, where they have some similar resources and have staff that don't necessarily normally do intensive care, but provide recovery care. And so in those times where you have these extreme fluctuations, you have to use resources that you can mobilize that will provide that can help provide that care. So, but I think the problem, as always pointed out, is this is kind of like a hurricane, and it's kind of sucking up all available resources, and it's sucking it up from every single place, from, you know, from the emergency department, from nephrology, from pediatrics. It's sucking everything up. And, you know, like yes, we can keep growing this population of patients, but it always comes at an expense. And it comes at the expense of providing a huge amount of care needs in non-traditional places. And that again comes with a lot of unintended consequences.
So I think one of the pictures that both of you have really painted quite nicely is the way that an ICU team comes together and works together, and everybody plays their parts. And my heart stopped for a second, Ellie, when you said that you were allowed to touch the ventilator, because I totally see how that's verboten. The respiratory therapists are quite controlling over that. So one way that I can sort of provide an analogy is that the ICU team is kind of like a pit stop in a Formula One race, where everybody, the car comes in, everybody goes, and everybody knows exactly what they're doing, and they work like a well-oiled machine, and they work together. And really, that's what you need in order to keep people alive, especially with diseases as complex as COVID. And so now what we're seeing in the fourth wave, and with the moral injury, with as Ellie said, some people are physically injured from having to prone patients, and moving that pit stop now, instead of where it's supposed to be, now it's kind of in a back alley somewhere. You're subbing in different people who maybe haven't done it before, or maybe they were on a pit team 15 years ago when they were training, but they haven't done it since. And obviously it's not going to function the same way, and you're not going to have the same sort of performance. And so consequently, patients suffer.
And that's, no one ever feels good about that. Providing less care than you normally would provide, it breaks our heart for sure. Like, you don't ever want to provide less care than you normally would. We weren't trained to do that. We weren't trained to triage these people to provide less care whenever you know that they require more. It scares me that there's, like whenever you are outside of a room and you have to get inside really fast, whenever someone's choking on their secretions through a breathing tube and you can't get in fast enough. Now, I was lucky to be at the bedside when that happened this weekend, and able to go into the room. But what happens when we're split so short that I'm taking care of 3 or 4 people myself, and I'm not able to see that person choke on those secretions? Then what's going to happen? So people will die because we don't have the resources. And I can't say enough about the people that have been redeployed to come and help us in ICU. They are a brave bunch of people. Like, we get, weeks of training to be able to go work in ICU. And then you're still terrified for a year before you get comfortable. So, to have these people come from different units. I also work labor and delivery at a hospital, and my peers from labor and delivery, delivering babies, have been redeployed to ICU at their site to go and help because they don't have anyone else to go help. So, these are both very skilled groups of people. They're very good at what they do, but talk about pulling them out of a situation and putting them in an absolutely foreign situation. Yes, they can react. Yes, they're very talented, but delivering a baby is very different from managing a ventilator or proning a patient.
So you both invoked this really haunting image of the way that you put it, Ellie, was that ICU is a family affair. And I'm not sure I'm ever going to get that out of my head. That's really terrifying when I actually, when my neurons made the connections of exactly what you were talking about. One of the challenges, of course, with this wave is that these infections are preventable with vaccination, and often resistance to vaccination, it might run in a family, or maybe there's a split opinion within a family. I think what some people might not realize is that a lot of ICU care is also caring for the family that's there. You have the patient, obviously, that you provide, physiological support, but then you also have the family that you have to provide a lot of emotional support. Can you guys comment on what sort of dynamics you've encountered in, this wave where vaccination status has been such a hot topic, and there's been so much polarization.
Why don't you go first, Ellie?
Oh boy, where do I start? It causes a lot of anger when you find out that you have an unvaccinated patient. It's been really hard to grasp that people have an opportunity to stay well and that they're not taking it. But we know that there's, a percentage of the population that's not going to do that. And we'd really hoped that with this fourth wave, we knew that a fourth wave is going to come. We didn't know that it was going to be this bad. We were really hoping for less, really hoping for less. It was funny. I came out of one of the rooms when I was working, and the person I was taking care of was unvaccinated. And I said to my coworkers, I'm so angry, but he's such a nice person. These are still good people. They're still good people. And, I've always given the benefit of the doubt to my patients. A lot of our patients don't take care of themselves and end up in ICU. This is good for business. I don't like it, but it is. This is what we operate off of. And sadly, it's really hard, and the staff are really struggling knowing that all of these patients, it could be prevented. And there are definitely family situations where, a patient will come in unvaccinated, but the rest of their entire family is vaccinated. Mm-hmm. And it has caused huge strife in their family. So I know that these things are happening in Albertans' homes. And I just say, I feel for you. I feel so bad for you because, it's absolutely, there's children that won't talk to your parents and vice versa. Because, there's disagreements on who, should you get the vaccine? And what if you don't? And, there's a lot of what ifs, but there are definitely, Albertans that are struggling at home with their loved ones choosing not to get vaccinated. And I just say to them, I'm so sorry. I feel so badly for you.
Yeah. If I can add to that, I think a lot of people genuinely just don't understand the gamble. There's a huge risk benefit calculation that each person does, that they think, in terms of the actual risks of their perceived risks of vaccination, which of course is in the eye of the beholder, right? Or those that are informed and uninformed. But there's also the kind of risk of COVID, and what do I think is worse? And yes, there are some people who are apathetic. There are actually a minority who I'd say who are staunchly anti-vaccine, but I actually think that probably is the minority of people who are actually anti-vaccination. I think most people just honestly don't have the right information. I keep hearing over and over again that I hear mixed things, and I'm like, well, but where are you hearing them from? And I hate to say this, but this falls squarely on social media, because the problem is the propagation of misinformation is so strong, and it's over and over again. And finally, the unfortunate part is that people have to be touched by it to realize how bad the problem is. And I see it time and time again. I see people come in and say, oh gosh, I didn't know how bad this was. I can't believe we took this gamble, and why did we do this? And it's if we only knew. And I've talked to family who keep telling me how come you're not out there telling people about the risks of disease and how bad this is? And I'm like, well, people are doing that clearly. So, I think right now we have a signal and noise problem, and we just can't get through to people because there's so many impediments to communication. And the truth is that most patients I've seen with COVID, that the first thing they say to me is, I don't know why I did this. I don't know why. Yes, there are the minority of people who are, like I said, staunchly anti-vaccination, but most are I don't know why I did this. And people say to me, well, I'm healthy. I don't know why I would take the gamble. And I'm like, yeah, but healthy, that is a stat. It's very hard on the individual person level to say that you're healthy and that you're going to be free from a problem when COVID strikes, because it's a host response problem. It just doesn't, unfortunately with COVID, as we've learned through each wave, is that being healthy is not necessarily protective, and that you may have an underlying condition or maybe not. Or frankly, I've seen lots of people who have no conditions and just have a really bad illness. And if they understood that was part of the calculus in their risk benefit calculation, I think they would have changed their minds initially.
Dr. Buchanan, with your work as a flight physician and STARS, is this wave behaving differently in terms of where people are able, or the number of people who are able to access high levels of care close to their homes than what we've seen in previous waves?
Well, I mean, like this wave is overwhelming, and what we've seen is surrounding Edmonton and Calgary, there's just not enough resources, and a lot of community hospitals do an excellent job providing care. But the trouble with COVID is it's like, someone comes in with breathing issues, they get put on oxygen, then they get predictably worse and worse and worse, and eventually they have to be transferred, because a lot of community hospitals don't provide ICU. And even if they provide ICU, they have a threshold at which they can't keep somebody for that long, because that person may need higher levels of care. And so I think what I've seen is, a lot of, frankly, just inundated hospitals around Alberta, which are struggling. And we also have issues on top of that with ground transportation and access to, EMS providers and practitioners. And I think this is, as I've mentioned, every time we've stressed the system. But I think now that, we have a very geographically diverse population, but also, unfortunately with Delta, we know that because it's so infectious, it really has touched, almost every town across Alberta, and in ways that are truly unfortunate.
Before we wrap up today's conversation, if you had a 1 or 2 sentence message that you could share with all of the Albertans watching at home, what would it be? Ellie, do you mind if we start with you?
Yeah, no problem. 1 or 2 sentences. That's a tough one. A big one is that we can't wait for the government to do something as individuals. I'm a nurse in a community, in a home. People knock on my door every day. We need to start taking responsibility ourselves, and we're going to have to bring that circle tight again. Because if the government is not putting restrictions in place, we need to be able to do that. I've got 2 kids at home that cannot get vaccinated, and it's just time for Albertans to bring the responsibility back to themselves and use common sense, and take the onus back on you to keep you and your family and your community safe. Get your vaccination.
Dr. Buchanan?
Yeah, I would just say kind of avoid the noise. The truth is, we know that COVID is a deadly and disabling disease. And, don't get vaccinated for me. Get vaccinated for your family, for your friends, for your loved ones. Just do it so we can all move past this.
Dr. Schwartz?
So I just want to express my gratitude to the healthcare professionals that are working in ICUs, the doctors, the nurses, respiratory therapists, the healthcare aides, the clerks, the cleaners, the clergy, the social workers, the physiotherapists, the occupational therapists, the speech and language pathologists. Just everybody is just doing such a phenomenal job under such immense duress, and so we really appreciate you. We also really appreciate all of the healthcare workers who are not who are not from the ICU and who are filling in this desperate gap right now. And so thank you to both of you for coming onto the panel today to give people a glimpse, and I hope that your colleagues can take comfort that Albertans really do appreciate what you're doing.
One of our value-driven priorities at Protect Our Province Alberta is transparency. And we have had very high engagement today in the YouTube conversation around a question that I'm not sure anyone on this panel today can answer, but I would like to share it anyway. So feel free if you have some thoughts. Folks are looking for advice. People genuinely want to know how they can convince the federal government to intervene if the government of Alberta won't.
Ooh. I mean, I think we need a collective voice. Like, I think, having this, like, Protect Our Province is an excellent way. But, I think that obviously, like, as healthcare providers, like, we've tried to advocate, because this has just been, it's been awful. But I think, having more and more citizens come together and demonstrate that this is what they want, that this is, like, what we live in, a democratic society. If people want this because they want to be safe in their communities, then they have to, first of all, express their opinions and show their support, and also vote.
Ellie, would you like to add anything?
I don't know what else to say other than to just try and, write letters if you need to, do these press conferences with people that are asking, just try and get the word out to let them know what dire straits that we're in. That's why we're here. We want people to know what is actually going on. I have nothing to gain from being on here other than to try and let Albertans know what's actually going on in our hospitals. I don't know how else to get a hold of the federal government. Write your MPs, get a hold of them, tell them to watch this and let them know what's going on in Alberta and that we need help.
Dr. Schwartz?
Yeah, I have no idea. I think it's important that we do exercise our voice. There's strength in numbers, so if you can corral your colleagues into putting your voices together, maybe you can add voices to colleagues from across the province, similar to what we've done with the infectious disease physicians. Otherwise start with your community, and hopefully there's enough of a groundswell that people will listen to us.
I guess I just want to add that I think it is, like, I will add that as an ICU physician, I'm sad actually that we're here talking about this and asking how to petition the federal government, because this is not something that we should need to do. Like, we need to have proper leaders that make hard decisions. And I don't think we need to shut down surgeries and cause problems for the global community just to have the leadership do their job. Like, I'm sorry, but this is not, this is not a time for asking for federal intervention. Like, realistically, we need our leaders to stand up and do what's right.
Thank you very much, Dr. Buchanan. And thank you, everyone who joined us today, from our panelists to the media and to the folks watching at home. This was the first panel where I was genuinely teary-eyed and goosebump shivering throughout. I don't believe that I will ever lose the quiver in your voice, Ellie, when you were talking about the texts that say critical staffing shortage. And thank you both just so much for what you are doing for our province and for the information that you have shared with us today. Today's been a lot. The news today across the country has been a lot. And today's episode has covered a lot of the challenges that are currently unfolding in Alberta's hospitals. It's important, I think, to note that even as all of this is unfolding, as both Ellie and Dr. Buchanan have said today, Alberta's medical professionals will care for you if you need help. And so even though we're talking about capacities and crunch in the system, please continue to seek primary, urgent, and emergent care when you need to. So many things are a lot right now, but you and your health, folks at home, really does matter. And please remember that these wonderful humans will be there if you need them. I think it's important to say that in the deep, there is also little bits of joy. joy that is found in community and in connection. And if you are looking for some joy today, may I suggest that you take a look at Julie Rohr's Twitter feed, an Edmontonian that we talked about last week when Nurse Rayanne Booker was with us. I promise you that you will see the joy that is coming out of the deep that I am mentioning right now if you take a moment to do that for yourself today. We will be returning on Wednesday with an update on the COVID-19 crisis in Alberta and a special focus on long COVID. Until next time, remember, COVID is airborne. Wear the best available mask you have access to, and vaccinations really do save lives. Thank you, and stay safe, everyone.